morning, everybody. Welcome to today's Public Health Ontario Rounds presentation on COVID-19 variants of concern. My name is Michelle Murdy, and I'm a public health physician at Public Health Ontario, and I have the pleasure of moderating today's round session. So before we start with today's presentation, I'll just mention a few housekeeping items. As you may have noticed, we have moved from Adobe Connect to Zoom webinars to host PHO round sessions. This was done to enhance the attendee experience and address the technical issues identified by previous attendees. You're welcome to let us know what you think by completing the anonymous evaluation that you will receive via email following the session. With Zoom, attendees have the ability to customize their own view by adjusting the frames between the presenter's videos and the presentation, while also accessing different interactive features of Zoom along the bottom of the window. During the presentation, you could submit content questions or comments through the Q&A pod. Questions will be consolidated and answered during the discussion period. For those that logged in early, you may have noticed some polling questions. You will be doing some additional polling during the presentation. Once polls have closed, you can view polling results by clicking the poll button. If you experience any technical issues during the presentation, please email events@oahpp.ca to get direct support. As we get started with the presentation, I'd like to state that as moderator and presenter, I do not have any potential conflicts of interest to declare. It's now also my pleasure to introduce the fellow speakers for today's presentation. I have Dr. Jonathan Goubet, medical microbiologist at Public Health Ontario, and Sandra Caldery, a senior advisor in health protection at Public Health Ontario. And with that, we will start our presentation. So if we could have the next slide, please. So just confirming none of the presenters have any conflicts of interest to declare. Next slide. And a reminder that this is a content developed by Public Health Ontario. Next slide. So the objectives of today's session are threefold. Firstly, we're going to describe variants of concern for COVID-19 and their role in the pandemic. Secondly, to describe the laboratory testing process associated with variants of concern in Ontario. And thirdly, to describe the infection prevention and control measures recommended for variants of concern. Our first polling question is, what proportion of COVID cases in Ontario are likely to be a variant of concern? Answers range from A, less than 1%, to D, 40% or more, or you don't know. And hopefully you'll have the results of that presentation through the content. Next slide. So to start off with, we're going to talk about today about variants of concern both internationally and within the Ontario context. So first, just to make sure everyone's on the same page about our understanding about what is a variant of concern, or VOC. So all viruses are changing constantly through mutation. When a variant has one or more mutations that differentiate it from other variants that are in circulation, then that's when it becomes a separate variant. A variant of concern is when there's clinical or public health epidemiological information to suggest that it is now either more transmissible, it can cause more to severe disease, such as increased hospitalizations or deaths. It can have significant impacts on antibody neutralization, either through previous infection or vaccination. It can have reduced effectiveness of treatments or vaccines, or it can cause diagnostic detection failures. So a variant of concern is when one of those becomes apparent. So multiple variants have emerged since the pandemic. Initially, there was an A lineage, and then a mutation occurred where B lineage arrived, and then a number of different lineages and variants have been detected across the globe. And we also see, previously back on that same slide, was still seeing multiple independent introductions of common mutations. So the two that we're going to talk about today the most is this N501Y mutation and the E484K mutation that are common to the main variants of concern. So this N501 is common to several variants, and then the E484 is common to some of the additional ones we're going to talk about. And just to make sure that everyone kind of understands about what this nomenclature actually means, here's an example of the E484 mutation. So in the original or wild type SARS-CoV-2 virus, you can see at the 484 position of the genome, there's the original coding, the wild type coding would have GAA, and that would code for glutamic acid, which is denoted by E. But now with that mutation to G becomes A, and now it codes for lysine, which is denoted by K, So we call this mutation an E because that's the original at the 4A4 position. That's now become a K. And similarly for N501Y, that's how that nomenclature would have been started. Next slide. So the three designated variants of concern internationally that have been declared, the first one being this B117 or 501YV1, which was originally identified in the United Kingdom. The B117 has just demonstrated increased transmissibility. So there's a range of estimates for about just how much more transmissible it is. Most of the estimates are around the 40 to 50% increased mark. There has also been several studies showing an increased risk of hospitalization when being infected by B117 compared to the wild-type SARS-CoV-2 virus, and similarly an increased risk of death. Fortunately, though, for the B117 is that there seems to be a relatively preserved immune response. So people who were infected before, when we take a look at their blood and see how it reacts to the B117, it seems like that there is still a good protection for previous infection, and similarly a well-preserved vaccine efficacy because the virus is still similar enough to the vaccine that has been circulating. The second one being B1351. So this is also designated as a 501YV2, and that all three of these do share that 501Y mutation. This one was really identified in the South Africa, and similarly has increased transmissibility. Again, estimates around increased by about 50%. However, its impact on severity has been less well established. The main issue with the B1351 is that it has shown significant reductions in vaccine efficacy. So predominantly by the E4A4K mutation that's part of the B1351, that seems to have now allowed this virus to become a little bit different enough from what's in the vaccine, that the vaccine just seems to be not working quite as well for the B1351. And similarly, case reports of reinfection by someone who was previously infected by wild-type SARS-CoV-2 and now infected by a B1351, causing fairly severe illness. The third variant of concern is a P1 or a 501YV3. So again, all sharing that 501Y mutation. And this one also sharing in common with the B1351, that E484K mutation. This one was originally identified in Brazil and similarly has some information about its changes to increased transmissibility and severity, but less well established than for the other two variants. And similar to the B1351, it has also shown reductions in vaccine efficacy, as well as case reports of immune response evasion of people becoming reinfected with the P1, but less so than the B1351. Next slide. So all three of these variants have been detected and present in Ontario. So looking at the numbers up to March 28th, the vast majority of the variants that we have seen have been in the B117 mutation, that's been the most we've been able to confirm. However, we do have detections of both the B1351 and the P1, and a large number of viruses where we know that there's some mutation present, but have not been fully characterized to say which one of the variants it is. So in addition to the three variants of concern that we had on the previous slide, there is a growing watch list. So in the US, the Centers for Disease Control have declared 2 additional variants of concern, both of which have been identified in California. That's a B1427 and a B1429. So these 2 variants of concern do not contain either that N501Y or the E484K mutations, but they both share in common an L452R mutation. This mutation has been shown to have about a 20% increased transmissibility compared to wild-type SARS-CoV-2, and some laboratory studies to show that moderate reductions in neutralization with convalescent or post-vaccination sera. In addition to these variants of concerns, there's also variants of interest, or VOIs, that have been designated as well. And these ones have some mutations in genetic markers that may potentially have clinical or epidemiological impacts, but those impacts have not been fully established to necessarily upgrade that VOI, the vaccine variant of interest, to becoming a true variant of concern. So a few of these would include the B1525 and the B1526, both of which have been identified in New York City and have been leading to rapid increase of cases in the New York City area. And another example would be the P2, similar to the P1, again, first identified in Brazil. So many of the common features of the variants of concern is an increased transmissibility. And there's a number of potential mechanisms by which increased transmissibility can occur and that are being investigated to understand why is it these new variants that they can cause more transmission to others. So one of the potential mechanisms is an increased fitness of the virus. So those mutations now give it that virus an advantage. So in one circumstance, it could increase the viral load. So if I was sick with SARS-CoV-2 as a variant, I might be now carrying a lot more virus in my nose and mouth, and that every time I cough or sneeze, that much more virus is getting expelled into the environment, making it more likely that I'm going to transmit to other people. Another example of that could be an increased period of contagiousness. So having an increased viral load or just carrying that virus for a lot longer means that I'm going to now be infectious to other people for a much greater duration of time, which also increases the likelihood that I'm going to spread to a lot more people. One of the other potential mechanisms is a change. That mutation now changes that configuration of the spike protein and the way that the virus now attaches to the human host cells. So one of the main receptors in our body of where virus enters our cells is through this angiotensin converting enzyme 2 receptor, or ACE2 receptor. And what we've seen in laboratory investigations is that this N501Y mutation can make it that new that variant virus now particularly more likely to bind tightly to that ACE2 receptor, so that even if you're exposed to a little bit of virus, that virus now has a better ability to hold onto that cell and become infected to the host. And the third way that we're sort of interested about increased transmissibility is that, normally if you've been previously infected or vaccinated, you would now confer some protection and make it less likely that you'd be exposed and infected again if you were to be re-exposed. But we're seeing that some of these mutations are changing the virus just enough that people with prior natural immunity or vaccination are not necessarily protected in the same way they were. So this last mechanism of what is it doing to vaccines is the most critical that we're investigating currently because of the current rollout of vaccines, and we're trying to make sure that we're getting people as vaccinated as possible and that we want the vaccines to work against some of these new variants. So on the good news side is that we have very compelling real-world studies of vaccine effectiveness from places like the United Kingdom and Israel, where the vast majority of what they're seeing currently circulating is the B117 variant. So one of the studies from Pfizer from Israel showed that there was still a 94% effectiveness against asymptomatic infection and a 97% effectiveness against preventing symptomatic disease, severe critical disease, or death. So that's a really excellent news story to say, what we're mostly seeing so far in Ontario with this B117 variant is that we're still going to get really good protection from the vaccines that we have. On the other converse side is that places like South Africa, where the vast majority of the variants circulating there is the B1351, and then Latin America, where the majority of what they're seeing is the P1 and P2, there is lower efficacy from some of the vaccines. So Johnson & Johnson did trials for their vaccine efficacy in the US, where it was mainly either the wild type or some B117, and they got a 72% vaccine efficacy. But when they did that same trial in Brazil, it was reduced to 66% and 60% in South Africa. Similarly for Novavax, when they did their trial in the UK, where it was mostly B117, they got an 89% vaccine efficacy, but that was reduced to 60% in South Africa. And then thirdly, for AstraZeneca, they did a trial for mild to moderate infection in South Africa and had a 22% vaccine efficacy. Again, mainly against that B135. Oh, yeah, and the next slide. So there was a nice summary in New England Journal of some of the information that we have about how well the vaccines that are currently circulating are working against the main variants. So you can see here that in the pre-existing variants, so that the wild type SARS-CoV-2, we're seeing really excellent protection from most of the vaccines against preventing clinical COVID-19 or preventing severe COVID-19. When we start to look at laboratory-based studies about how well neutralization is happening from the antibodies produced by vaccine, we start to see reductions, slight reductions against the B117, and then more significant reductions against the P1 and the B1351. And then in clinical studies, where we're actually looking at about efficacy in settings where the B1351 is largely circulating, we're seeing more moderate to severe reductions in vaccine efficacy. Next slide. So what does the picture look like in Ontario? When we started detecting the B117 mutation probably from about mid-December of 2020 onwards. Initially kind of low percentages of detections, as Jonathan will speak more to, but over time we have seen that number grow quite significantly. So we're seeing now that recently towards the end of March, close to 60% of all positive cases in Ontario are likely to be from a variant of concern. And again, the vast majority of that would be the B117. But also now starting to look for other ones like the B135 and the P1. We also have some increased data, some preliminary data about increased transmissibility within the Ontario context. So we were able to look at household secondary attack rates, where index case was a VOC versus a non-VOC, and again here the VOC mainly being a B117. We saw there was about an overall 30% increase in secondary attack rate amongst household members, and that was consistent with similar findings in the UK. But there was also a particularly higher secondary attack rate when that index case was either asymptomatic or pre-symptomatic, going as much as 3.4 risk ratio higher. So, one of the main issues there being that the person doesn't even know that they're necessarily infected, and yet having a higher transmission to others in the home when they're not even aware that they're infected themselves by being asymptomatic or pre-symptomatic. We're also starting to see similar results in the size of outbreaks that are likely to be due to a variant versus not. So looking at outbreaks across a range of settings from congregate care, congregate living, education, and other settings. Most across the board, we're seeing slightly higher median cases per outbreak when there's a VOC detected compared to not. Probably the most dramatic here would be in the congregate care setting, where the median cases were 2, whereas that's now increased to 8 when there was a VOC detected. So what is the response to these variants then? Well, fundamentally, we need to limit the circulation of virus. The more virus is replicating, the more likely that mutations will occur. And preventing that amount of mutation opportunity is what's key to preventing new mutations and variants arising. And that's how we're going to eventually have fewer variants in circulation. So this is going to really require strength and maintain public health measures, as well as the rapid rollout of vaccines to try to reduce the number of infections globally. So we need rollout of vaccines both domestically and internationally where other variants of concern may arise. We also need to see a limited spread from cases that are infected with VOCs. So we have, in Ontario context, increased our case and contact measures in response to the increased transmissibility associated with variants. And then we may also need to consider further measures. So with the concern that we have vaccines, but if there's vaccine escape potential, how can we now adapt our case and contact management in considerations of those variants that may be evading some of our protections from vaccines? Next, we need to have a robust testing and surveillance for variants that Jonathan will be speaking more to. And finally, also a real-world assessment of how well our vaccines are performing against the emerging variants of concern. So with that, I'll turn it over to Jonathan.
Okay, thanks, Michelle. Good morning, everyone. So I'm just going to discuss some of the lab testing that's being done for VOCs in Ontario and some other surveillance projects. So we just go to the next slide, please. So this is some of the stuff that Michelle has already covered. But as you can see, when considering developing lab testing for the 3 most talked about and most prevalent VOCs globally, the B117, 1351, and the P1, we do need to look at what mutations they share and which ones potentially could be used to differentiate them. So you see the N501Y mutation they have in common. The E484K mutation is only found in the B1351 and the P1 lineages. There is a third position, the 417, that both 1351 and the P1 have mutations, but they can be differentiated because, as you see, for the B1351, it's K417N, and for the P1, it's K417T. And a collaborator of our genomics team has come up with some sort of mnemonics to help people remember which mutations go with each other. So we've used the terms Nelly, Eek, and Pooh. That helps. You can go to the next slide. This is just showing that these two, what are currently variants of interest in Canada, but variants of concern, according to the CDC, they do carry a mutation that could also be used to screen for them, the L452R, which Michelle also showed previously. I believe this mutation is also found in other lineages, so it wouldn't be a diagnostic detection, but it could be used as a screen. Next slide, please. So there are several different testing modalities that can be used to test for VOCs. One that can be used is the S-gene target phase that I'll explain in a subsequent slide. We can also do real-time PCR testing for variants of concern. And that's the main modality that we're using now in Ontario, including the public health lab. And then the definitive way of confirming and classifying VOCs is through genome sequencing. The challenge with that modality is that it's very time consuming. Next slide, please. So if we look at S-gene target failure, what is happening there? So really by a coincidence, in the UK, they were using a particular assay by a company named Thermo Fisher. And it just so happened that the S-gene target there is targeting amino acid 69 and 70 in the spike of protein gene. And due to this mutation at position 6970, the S gene target is basically missed when this assay is run. So what they were seeing was a whole lot of samples that were negative for the S gene target, but strongly positive for the other two targets in that assay. That is the N gene and the ORF1ab. There is another commercial assay that's Health Canada approved that also misses the S gene target called Ningbo, but I'm not actually aware of any labs using it in Ontario at this time. Next slide, please. So this slide actually nicely shows how the UK were able to use the S gene dropout feature to map the evolution and rapid rise and the prevalence of the B117. You see here the weekly prevalence dramatically increased from 5% in early October to almost universal by late November. And that's shown here with a black line. And then with a red dotted line, you can see what was actually done with confirmatory sequencing followed a similar path. Next slide, please. So in Ontario, the first test that we implemented, and it was designed by one of our research technicians, Reza Sagi, was a real-time PCR target that is more specific and directed specifically at that 501Y mutation. And it's termed a single nucleotide polymorphism real-time PCR. It is a bit less sensitive than our SARS-CoV-2 detection assays, so requires the CT value to be 35 or below. And we have been screening all SARS-CoV-2 positive samples in the province since February the 3rd. At least that is the goal, and as many as possible that meet our criteria, the CT criteria being screened. Next slide, please. So different ways that surveillance could be done. There are guidelines by the Canadian COVID-19 Genomics Consortium that I'll show in a subsequent slide. We've done some point prevalence surveys. There was one done on November 24th. That was done prior to the evolution of the VOCs, but we have looked at the data. That was the whole genome point prevalence survey, and we did not have any VOCs in that subset. Most of you are aware that on January the 20th, we did a point prevalence survey in Ontario. That showed that only about 1% of non-outbreak samples were VOCs, and practically all of them were the B117 lineage. There was a couple of large outbreaks in one health unit that skewed the data for outbreaks, but it was only about 2% of individual outbreaks that had VOCs. And as I said, that since February the 3rd, we're basically screening all positive samples that meet our criteria. Then there's additional surveillance that can be done because in order to detect all emerging VOCs, we can't just take the biased approach of screening for known mutations. We also want to do some background of whole genome sequencing. So we're aimed to do approximately 5% of all non-VOC positive samples. we're also doing whole genome sequencing for at least a couple of samples from every outbreak in the province. And PHO, as well as some partner labs doing sequencing, have been doing baseline whole genome sequencing since the middle of last year. Next slide, please. So I'm going to skip over this slide, but the information's there. A lot of these criteria I'm mentioning through the other slides that you're seeing, but the information is there. It's just showing what the initial criteria were that we were using that are based on the Canadian Genomics Network guidelines. So we can go to the next slide now. So on March 22nd, we then moved to another real-time PCR assay. What we did was, with the rise in the 501Y mutation and the importance to have rapid screening for the P1 and B1351, we've added a second target to the real-time assay for that other mutation that we've been talking about, the E484K. So now when samples are screened, if they're just 501Y positive, using the historical data we have that we continue to monitor, it's over 95% of specimens that have 501Y present but do not have the E484K mutation, they will be B117. So we're stopping testing there, and they should be presumed to be B117s when you get a result that says 501Y present, but the 484K is absent. Any samples that have the E484K mutation, whether or not it is with the 501Y, they are reflexing to whole genome sequencing to help differentiate whether or not the P1, B1351, or they could be other lineages that carry the 484K but are not in those two specific lineages. One important thing is that to do whole genome sequencing, we do need a bit higher viral load than with the real-time assay. So we require the CT value within the dual target real-time assay of the 484 target to be at least 30 or below. And if not, we add a comment to basically say that we're not able to test any further due to the low viral load, affecting the quality of any subsequent sequencing that could be done. One important question is really at what prevalence threshold of VOCs should we stop testing every sample? At this time, we are continuing to do all specimens because it is providing a stable method of surveillance for the province. But this will definitely be reassessed as prevalence continues to be monitored of the different VOCs and the particular mutations we're able to screen for with real-time PCR. Next slide, please. This is just a sample report that a lot of you have probably seen already, where in this dual target real-time PCR, you'll note that we really just mention which mutations are present. We intentionally have not said, like when it's the 501Y only, this is most likely a B117, just because of the changing epidemiology. We do have that information on our website on some ancillary documents, but this is intentional because of the potential need to change the sort of interpretation, and sometimes the lab information systems can't be updated as quickly as would be ideal. So next slide, please. And this is what you would see when say the SARS-CoV-2 PCR was positive, but in this real-time assay, we're not able to detect any of the targets. So we can't comment on whether or not there is a VOC there, and we just put a comment unable to complete and explain what that means and reiterate that the sensitivity is lower compared to the detection assays. Next slide, please. This is just a screenshot to show you that we do have a lab abstract that explains this new dual target assay, and we can go to the next slide. And that lab abstract is found also on this test information sheet for variants of concern that we have, and that provides a lot of the information I've just been talking about. Next slide, please. And again, the wording on like how we do the sequencing is also available there. There's also a Q&A document linked to the test information sheet that it's worth taking the time to have a look at. Next slide, please. And here is just a sample whole genome sequencing report where we outline the key mutations that were detected, and then whether or not it's a VOC and which one. In the future, you may see some changes in this report where we may not identify the individual mutations, but just clearly let you know what VOC or whether there is not a VOC present. Next slide, please. So just some other uses of whole genome sequencing to be aware of is we will do whole genome sequencing when there's a suspected reinfection, because they're always at risk of new lineages or new mutations arising. Anybody who's has an infection post vaccination, our current intention has been to do it after, when it occurs more than 14 days after completing the vaccine series, but we'll be reassessing that given that currently the gap between immunizations has been spread to several months. So we'll likely be willing to look at it even after one dose, probably beyond 2 weeks after having had one dose if there's an infection. And as I mentioned, to support monitoring what's going on in outbreaks, we'll be using them. But also when there's questions about transmission within outbreaks, we can do them, but we don't recommend that really be done routinely. I'll be talking a bit more about that in a subsequent slide. We aim to sequence all infections associated with travel, and as I mentioned, the background surveillance for novel mutations. Next slide, please. So as I just mentioned briefly, whole genome sequencing can be of some assistance when investigating individual outbreaks, but we have found that that often it does not add a lot of information beyond the solid epidemiology that can be obtained on the ground. When there are specific questions that need answering, it can be discussed with our lab to see whether it would have any utility. Here's one example where it was able to confirm linkages within the outbreak, but I can't comment whether or not the epidemiology would have already answered for this particular case. But within the outbreak, we see there weren't more than 3 base changes within any 2 cases, but even the reference is not that far apart, but it was 6 changes, 6 mutations different. So you could group there who was in and who was not. If we go to the next slide, but we do caution, because even in the surrounding community, you may have identical sequences. Here's one investigation that was done where you have the outbreak cases in grey, and then from a totally unrelated long-term care home, you have identical sequences, and then from the surrounding community again. So it's not always mapping one-to-one, that if you have identical sequences that you can say that cases are epidemiologically linked. Next slide, please. And just to let you know that PHO is launching a website in collaboration with Next Strain. We're actually going to be posting all of our sequences, and I believe other provincial sequences will at some stage be added to this database as well. And it's publicly available. You can go on and actually create your own trees and look at the lineages that we have in Ontario. I believe we're aiming for this to be live towards the end of today. If not, it should be up by tomorrow. And you'll be able to access that through several of the links that I've already shared, such as the test information sheet or PHO's data page for COVID-19. We can go to the next slide. Okay, so I'll hand over to Sandra now.
Thank you, Jonathan. And we'll begin with the following slide and talk of variants of concerns and related to transmission. And I'm going to focus on the infection prevention and control components. So based on the epidemiology of COVID-19, transmission predominantly occurs with respiratory droplets when in close contact with individuals who could be symptomatic or pre-symptomatic, or less commonly asymptomatic, and unprotected contact, of course, as well. Transmission over longer distances is less common, and sometimes we can see transmission in prolonged exposure in a very poorly ventilated space. So those are conditions that we always take into consideration. And virus transmission with fomites likely occurs, but this is believed to be less common. So with the predominant mode of transmission via respiratory droplets and reviewing the evidence with VOCs, there really is no difference or no extreme difference in the modes of transmission of VOCs that has been seen with the non-variant. So VOCs and non-variant transmission seem to be comparable. Next slide. So with that in mind, the Provincial Infectious Diseases Advisory Committee, or PIDAC, recommends that we continue with droplet and contact precautions, continue with physical distancing greater than 2 meters wherever possible, and really no recommended changes to personal protective equipment. And remembering that although it's easier to transmit, all of those same measures need to be there, be carried out consistently. And remember, the IPAC measures work as a team. It's a suite, if you will, of measures that work effectively when they're all implemented. So those are the key messages there. The next slide, please. We do know that there are other areas that have responded differently to VOCs or variants of concern. And so we did look at the response by other jurisdictions. So PHO conducted a jurisdictional scan on mask use, and specifically, that's probably been the highlight that people have been looking at, or most questions are coming in around masking. So we do see here that about 11 of the 14 jurisdictions that we reviewed, regions and countries, have not actually made any changes or updates to their masking guidance. This actually includes England, where we know the B117 variant is the dominant circulating strain. So it's certainly, when we look at Austria, France, Germany, the 3 jurisdictions that did shift and change their policies or their protocols, it was actually around public masking policies, and recommending that they look at medical masks or an equivalent. And the rationale given was for filter efficiency and more consistency with fit. Next slide, please. Another area, another jurisdiction that we looked at closely was in Quebec. Many have seen these reports as well. And after restricted use of N95 respirators to very specific aerosol generating medical procedures, Quebec has added the use of N95 respirators in what they're calling hot zones. And that's been effective since February the 9th. Now, hot zones, you can see here a description of what that means. And on the next slide, when we look at the documents that Quebec has produced, they have not actually brought forward new evidence around within that review. And in fact, the evidence that they did bring forward is well aligned with Public Health Ontario and the Public Health Agency of Canada. So the routes of transmission align, and there's no really direct evidence of long range airborne transmission noted within their document. And also the document summarizes that the available evidence really suggests equivalence between respirators and surgical medical masks. So on the next slide, the PIDAC recommendations then are that because there's no evidence that variants of concern are transmitted in a different mode, they are not recommending any changes at this time for N95 respirator use. And we also want to note that healthcare workers are reminded that Directive number 5 actually provides a healthcare worker with the prerogative to use a respirator when their personal risk assessment warrants this. So next slide. We've talked about healthcare settings and double masking, or the knot and tuck. So another jurisdictional scan and other reports that many of you have heard is around the measles, the medical MMWR, the Morbidity Mortality Weekly Report. And in there, they talk about a double masking or a knot and tuck. And this is really, double masking is referring to that tight fitting cloth mask that would be worn over a medical mask. And the knot and tuck is actually describing tying off the ear loops a little tighter, closer to the mask itself, and then just tucking in the extra material into the gaps so that it fits more snugly. The report described an experimental simulation study, and they actually used mask dummy head forms. And they only actually tried out one cloth mask and one medical mask for this experiment. Next slide. So they found with this simulation, they found that if you were looking at source control, both the double mask and the knot and tuck concept did seem to prevent more particles being generated and escaping around the mask. It seemed to reduce that number of viral particles. The exposure protection, which is really protecting the wearer, also found that there were less viral exposure, as you can see, with both the double masking or the knot and tuck. So those modifications seem to be effective. This is a lab simulation only. And what does it really mean in real world situations is unclear. And it had very limited study in design and did not really work with a lot of different mask types. Next slide. So in our healthcare settings, PIDAC's recommendation is that both for universal masking, which we know we have in place, and masking as personal protective equipment, we still recommend medical masks for staff who are working with patients, working with residents, working with clients. And double masking of medical masks is actually not recommended. And in fact, the evidence shows that previous outbreaks have been managed without the double masking concept. And those the evidence are in previous outbreaks in Ontario. There are certainly medical masks are designed and tested for performance, and manipulation of the mask could really cause some unintended consequences. And so manipulating a piece of protective equipment, it's really important that you consult with occupational health and safety before changing or manipulating the design of a mask. Next slide. So that, talking about patient masking, PIDAC has actually looked at the epidemiology, and it shows that there may be some protection to the patient and the resident. So where healthcare settings expect patients to be masked, the healthcare setting really should be providing the patient with a medical mask, unless of course there is a contraindication. And on the following slide, we have examples of patient masking. So when you, as a home care nurse, for example, or PSW, going into the client's home, ensuring that the patient has a mask as well as for yourself. In all areas of an outpatient healthcare facility or exam rooms or treatment rooms, in acute care facilities, and particularly if in your room you have a lot of care being provided by healthcare providers within 2 meters of the space around the bedside. In multi-bedrooms, if a patient is ambulatory and may come within 2 meters of another patient, wearing a mask would be appropriate. And in long-term care or retirement home settings, resident masking may actually need more flexibility. It's not always tolerated, but resident masking when outside of the room should be supported when it's requested by the resident and they are interested in and able to wear a mask. Next slide. So eye protection is part of the component part of the protective apparel for droplet precautions. And it's important to note that prescription eyeglasses are not eye protection. So eye protection is a device that should cover the eyes from all sides. And we do have safety goggles, face shields, visors, and even some safety glasses that would meet the outcome criteria that we're looking for. Next slide. So people remind me every day that we've been in this for now more than a year, and how do I stay engaged? You're telling me to carry out the same precautions, the same measures, And how do I stay alert? How do I not become complacent with my practices? And how do I stay vigilant? Because each of these IPAC measures are really important, as we've said. So screening questions, they can become mundane. How do I stay in the moment? How do we engage not only our screeners who are asking the questions, but how do we, what strategies can we give to our staff to make sure that they're actually taking a moment and reflecting on how they're feeling and going through their risks each and every day? Are my staff trained on donning and doffing of protective apparel? And it's not only making sure they've gone through a module, but how often are they observed, audited, and provided feedback? Because there's some early evidence to show that this actually makes a difference in transmission within different healthcare settings. Don't forget about agency staff, or the people who are temporarily within your facility. How have they been trained, and how have you been observing them as well? Where we have found, when we've done close observation of our outbreaks and analysis and assessments, we have found that people are often very good at the bedside or just outside the patient or resident's room, but they often let their guard down a little bit when they take a break, go on coffee and meal breaks. So our staff overextending the use of their masks or their eye protection, and how have they maybe gravitated to too many in a lunchroom or a break room? So making sure that we've given them space to accommodate the break time. Safety coaches and morning huddles have been found to be very effective. So, and sharing positive outcomes is really helpful as well. Next slide. Environmental cleaning and cleaning of high-touch surfaces really hasn't changed. Yes, although fomites can still occur, and transmission is less common, but it can still occur. And so we're keeping the environmental cleaning practices the same. Close confined spaces, making sure that rooms that have been repurposed for a small break room or for another reason are well ventilated, to avoid that accumulation of aerosols. Make sure the HVAC systems are in compliance and that they're receiving regular maintenance. Ensuring that there's sufficient break space. So making sure those spaces give you enough distance, physical distancing, and making sure that people are not, as I said, letting their guard down a little bit and having those quick chats, maybe without protective apparel on, and people aren't seeing those as primary means of transmission. So keeping an eye on that. Next slide. So cohorting and patient placement. Well, first of all, in most situations, necessary transfers should proceed without appropriate, with the precautions, and the transfer should not be delayed because the patient's VOC status is unknown, for example. Outbreak management from an IPAC perspective remains much the same as well. And certainly facilities need to continue to consult with both their IPAC consultant and their public health experts around any VOCs that they may be dealing with, and VOCs that are not yet widely disseminated in Ontario. In terms of patients with COVID-19 due to B117, they can be cohorted by PIDAC's perspective. They can be cohorted with other COVID-19 positive patients, as long as there's no other additional contraindications to this. And in the absence of any information, patients with a known VOC other than B117 should be in a private room wherever that is possible. The indications for the use of any airborne infection isolation rooms are the same with VOCs as we have applied for the non-variant SARS coronavirus. And discontinuation of precautions, really no change in the approach there either. Next slide. So in summary, IPAC practices really remain much the same. There's really no evidence that there's a difference in the modes of transmission between variants of concern and non-variant SARS coronavirus 2. So maintaining those transmission-based precautions with higher transmissibility, just remember the being vigilant with all of the IPAC practices. And on the following slide, we have here resources through Public Health Ontario on variants of concern. We have a main page for this. Many of the topics discussed today you can find there as well. And we also want to acknowledge on the next slide, many people and organizations who have helped support this particular presentation. And we thank them for all of their support and their input. And back to you, Michelle.
Great, thank you so much, Sandra and Jonathan. So we've been trying to answer a few questions in the chat pod, but we do have a number of questions I thought would be helpful for the speakers to address now that we have a few minutes left for a discussion period. So continue to encourage participants to add speakers there. So I think there's a couple for you, Sandra, and I think you did cover both of these in your remarks during your presentations, but in case there's something you'd wish to highlight. One is there any evidence that transmission of variants is not by the airborne route? And the second was around, is there any new information regarding PPE as it relates to the new VOCs?
Yeah, so I think I'll start with the second question. So in terms of the protective apparel that has been recommended for non-variant coronavirus, it's still very much relevant and for the VOCs. So no changes there as we have stated. In terms of true airborne infection, this has not been seen. What we have been concerned about, as I mentioned in my slide deck, was really around close confined spaces where there is not good ventilation. And so you can have a higher number of aerosolized virus, and that's of concern if there's no escape. And so it's the volume or the exposure to a high degree of virus in a smaller closed enclosed space. So that's where we're concerned, but no other evidence to date.
Great, and there's another question I'll read out and start to answer, and then Sandra might be, if you wanted to add. So it's a question about if we could speak more about prevention measures. Do the same measures like distancing, masking, hand hygiene, and respiratory etiquette remain effective against new VOCs, or should we be considering additional measures? And if so, is further guidance coming? So I'd say, I think Sandra's highlighted, that we don't think there's any different mechanisms of transmission with the VOC or not, but the increased transmissibility means that, there are regular interactions may result in transmission from before. So all of those prevention measures are still incredibly important. And I think it's the layering and attention to adherence to each of those measures that what we really need to do to try to combat that increased transmission. So, before maybe people were, doing some of these things well, but not all of them. And I think it's hard that we're now, a year into the pandemic, and we've been asking people to do these things for a long time. But even more so now with some of these variants, the increased transmission, that we really need to be paying attention to how well we're doing each of those, and that we're using all of those measures as best as we can.
And thanks, Michelle. And the only thing I would add is that we have actually been examining hundreds of assessments that we have been going through outbreaks that have been occurring across the province. And in close observation, as Michelle has pointed out, we find that people are doing some components very well, and then others have had less attention. And I think because of the ease of transmissibility with VOCs, you have to realize that they all play an important role. So all of the measures that we have put into place need to be addressed. And that's why it's really important to look at your checklists and make sure that all of them are being handled accordingly.
Great, thanks, Sandra. We do have a couple of questions for Jonathan. So first question, Jonathan, is there interest in exploring alternative tests to replace whole genome sequencing for detection of VOCs?
Hi, thanks. That's a great question. I think there's this difficult balance between if there is a way to detect particular VOCs more quickly, how much does it make sense to invest in working on setting up a new test that would initially be done probably PHOL and then be fanned out to our testing network, yet potentially 3 to 4 weeks later, that particular VOC may be so prevalent that there isn't a lot of utility in actually detecting it. And I think a prime example is the 501Y, the B117. Probably if we were starting now, we may say that there's no need to necessarily have that in every test that's being done if we were really beginning right now. But like one thing that we have done is if we find the 501Y alone, as I've said, we are not going on with the whole genome sequencing because it does map so directly. And that was in our attempt to also help get quicker information. We've added the 484 target so that we can quickly let you know whether it's potentially one of the other 2 key VOCs. But we will be continually assessing and reassessing the way that we do the testing. One thing we have learned is that it is an enormous challenge to our laboratory testing network to change the testing parameters every few weeks. If we think historically, when you're introducing new tests, often that's a process over months to potentially years when labs are planning and bringing on, validating new tests. So it's pretty, it can be a challenge to be doing this on a several week basis, introducing new tests. So I think eventually we're going to have to make some decisions based on the prevalence of VOCs, how longer we need to detect every single one in every sample, and then recalibrate the way that we test for them.
Thanks, Jonathan. There's another kind of lab-related question that I'll read and I'll maybe start an answer and happy for you to jump in. So the question is about, have we found reinfections or infections in vaccinated people? What about staff in long-term care testing positive and routine surveillance or hypertension? So I think, in relation to CD, what we present to VOCs of what we presented, that, is there vaccine escape? So is someone getting infected even though they've been vaccinated in Ontario? So I think just to qualify that, we do expect a certain number of people who have been vaccinated to still become infected. So we definitely see it, right around the time of vaccination. We know that the vaccine, as soon as you get it, it takes a while for that first dose to become effective. And then again, with the booster, have even more protection from that vaccine. So really kind of not until, at least 2 weeks after that second dose is when we would expect the maximal amount of protection that you're going to get from the vaccine. But even then, even at 95% effectiveness, that's still saying that, 1 in 20 could still be infected if you were all to be exposed. So I think some degree of breakthrough infections are to be anticipated, and that's regardless of variants of concern. But certainly, because we are concerned about these variants of concern, then everybody who would be positive, at least a couple of weeks after vaccination, we are trying to send forward those positive results for testing to see, could it be because of a breakthrough, because of less protection against a variant of concern? So I don't know if Jonathan, you want to speak a little bit more about that process?
Yeah, so as I said earlier, we spoke about it and felt that, especially as we were getting more and more sort of communications about people coming up with infection in the early days after immunization, that we decided to say, okay, let's go with 2 weeks after completing the immunization series. And that was done before the interval had been significantly increased. So that if we were alerted about those, then we would arrange to make sure the sample comes in here and that we will set it up for whole genome sequencing, regardless of whether or not it is a VOC on that screening. But we are reassessing that, given that we are going to have a lot of reports of people who've had 1 dose of infection, which by around 3 weeks is going to be probably at least 80 to 85% effective. So we'll probably say that after 1 dose beyond, and we'll stick to the 14 days to keep it simple, that we would be willing to have those come in for sequencing and be interested in receiving them. So if you just get in touch with us, we'll give you some information on how to get the samples to us if they weren't already tested at our lab. And of course, it's very helpful if that is documented on the requisition. We do have space now to document the vaccination status on the requisition.
All right, so we're getting close to the hour. I probably have time for a couple more questions. So I think, Sandra, there's just kind of one brief clarification here on if the labs are moving away from sequencing specimens that only have the N501Y mutation, is it still appropriate to cohort those with this mutation?
That's a really good question. I think if it, and perhaps if we're looking at, I would have to probably go back and take a look at what PIDAC would say about this. Certainly, if it's a B117 and we're considering that particular variant, we are comfortable with people being cohorted together with another positive case. But I actually would, I really don't know how much evidence we've had or experience we've had. So I'll just pause there in case Michelle or Jonathan have another comment
I
on
would
that.
state it from the lab point of view. I'd say it's probably about 98% of ones that are 501 positive, 484 negative are B117. So it's almost mapping 1-to-1 at this time.
So, yeah, and so in that case, we would continue to be comfortable then with the cohorting.
Okay, I'm going to take one last question, and just to remind all participants that we do collect all the questions that are posted, and we'll try to provide a way to some answers if we didn't get a chance to answer them in the session today. So last one was saying around assessing risk of transmission with VOCs. Is the period of communicability now increased from 48 hours prior to symptom onset or date of testing for asymptomatic cases? So we have remained in general, we are still keeping with the 48 hours prior to either symptom onset or date of testing for asymptomatic cases. We do know some jurisdictions have moved to longer, that we know that there can definitely be reports of transmission that happened 3 or 4 days prior to either symptom onset or positive result. In general, just to prioritize the efficiency of contact tracing, we have kept it as 2 days before that time period, but certainly we have seen sort of an individual level, when there is uncertainty about when exposure or onset may have occurred, health units have tended to increase that and take a bit more of a wider berth and maybe include up to a third day before in their contact tracing. So yes, certainly I think that is kind of reasonable to have it be a little bit, generally still using the 48 hours, but if there's concern about transmission, to include a longer time frame prior to symptom onset. So I just wanted to again thank you to Jonathan and Sandra for presenting today, and for all the participants for joining the session. Please look out for the evaluation email that will be coming to you and giving us feedback on the session today. And thanking everyone very much for participating, and hope you have a great day.